There we go. So this edition is about recent advancement and diagnosis and treatment in veterinary epilepsy. And just a little recap that we are the seizure clinic. We are a veterinary neurology service with a specialized service, which is called the seizure clinic, where we focus on treating epileptic dogs and cats. We have our own dedicated website in which you can find several fact sheets, our events, and this website is ongoing, but you can also find all of our post events there as well. Today I'm joined by Ada instead of Pauline. So Ada is my sidekick. She's also a part of the biology team. Hi, Ada. And she might occasionally just jump in when we have questions for the chat box. So this evening's edition is about diagnosis and treatment, but we're not going to cover the most kind of conventional ones. So we're not going to go over the basics. We're going to go diving a little bit deeper. So maybe thinking a bit more outside the box. And I wanted to start off with an anecdote. So in this story, it was 2 a.m. when Bella had another seizure. Her owner, Sarah, sat on the kitchen floor, cradling as her tremors passed, whispering, "You're okay, baby, you're okay, I got you." It was the third one that month. Her meds weren't working anymore, and Sarah felt helpless, trapped in the cycle of watching and waiting, fearing the next time. The vet had told her that the medication might not stop every seizure, and at first it helped. But lately, things were getting worse again. More seizures, longer ones, and a growing sense of helplessness. Like so many other dog owners dealing with epilepsy, Sarah was doing everything she could and still wondering if it was enough. Now, I can imagine that many of you have been in this position and have shared the same feelings. But I hope also with this talk that we can look a bit more brighter into the future. And what if we could change this story? So we've come quite a long way in epilepsy. So historically, epilepsy had lots of stigma and still has, to be honest, but it's always was found to be feared, avoided, concealed. Even in the time of the Babylons, we saw it as the falling disease, and they thought it was that these people were possessed by demons and ghosts. But over the past century, we have made a lot of advancements, especially with further diagnostics such as MRI, which is advanced imaging of the brain, looking at the brain waves. So we definitely have come a long way. So there's hope. And there's over the recent years, there is definitely a lot more research out there. So before 1980, we only had maybe 1 or 2 drugs and that was it. So if you were exhausted of that, then that was you done. Luckily, we have more and more medications and we have other types of epilepsy treatment as well. So although it still seems like we have a long way to go, we definitely have come far in the last few years only. So tonight's structure, I would like to go over a little bit of the basics of epilepsy diagnosis and treatment, which just some true and false statements, and you can have a think about it yourself. Then we have the top 7 of what's new nowadays, and then a little bit on future research topics. As with the last time, if you have any questions, put it in the chat box. I'm not able to look at it whilst I'm talking, but my colleague Ada, if there's any specific ones that we want to discuss, we can pull them up and discuss them as we go. I'm happy to be interrupted. Also, if you have a really urgent question, just unmute yourself. I'm fine with that as well, of course. So going to the top 10, true or false. So the first one would be a single seizure means a dog has epilepsy. So it has a seizure, your dog has epilepsy. Advanced imaging of the brain and spinal fluid analysis are not always necessary to diagnose idiopathic epilepsy. Phenobarbital is no longer recommended because it's outdated. So the first one is false. So if your dog has 1 single seizure, it doesn't mean that your dog has epilepsy. We don't necessarily call it epilepsy. It could be a reactive seizure, meaning that it had a toxin and it's just a one-off. However, if it's more than 24 hours apart and it has multiple unprovoked seizures, then yes, we will call it epilepsy regardless of the underlying cause. The second one is true. We don't always need advanced imaging. Actually, in most of our cases, when they're in a specific age group and they are normal in between and they fit certain criteria, an MRI of the brain or spinal fluid analysis is not necessary, and we can have a presumptive diagnosis of epilepsy without any underlying cause. So that's not always necessary. Phenobarbital is in people maybe a bit more outdated, but for us, it's definitely a very, very reliable drug. It has a high efficacy. It's easy to use. We know a lot about it as well. We know that it has lots of side effects and lots of things that we don't like about it, but there's a lot of information out there about its efficacy and also on how we need to deal with it. So before we weren't so good in monitoring it, now we know exactly what we can expect when we use this drug. So the next three, newer medications like Paxion and Keppra have fewer side effects. Diet and supplements can play an important role in managing epilepsy. If seizures are not fully controlled, treatment has failed. So these medications, yes, they have lesser side effects. They still have side effects though, so it's always something to consider. And we always need to balance it off with their efficacy. So usually when they have lesser side effects, they may not be as strong. So they're not always suitable for every patient, although we'd like to benefit the fewer side effects. Then the second is correct. Diet and supplements can definitely have an important role, and it is very patient specific. So some dogs are very sensitive and they may benefit from having a good look at their diet. For others, it may not be as important, or it's not as effective. Then if seizures are not fully controlled, unfortunately, we barely ever can control them completely, that they go away. So we never aim for seizures to go into remission, because we're going to set ourselves up for failure. So yes, it's possible for a dog to go into remission, but it's not common. And we need to consider that very often the seizures will continue. So treatment is not just only seizure control, it's also having a good quality of life, being able to manage the seizures, basically continuing your normal daily life with this condition. Then the last four, epileptic dogs are always mentally normal between seizures. Cluster seizures and status epilepticus are emergencies. Regular seizure diaries are useless unless the dog is on new medication. And once a dog starts a drug, they always need to be on it for life. So the first one is not true. Many dogs are normal or classified normal in between their seizures, but we definitely see dogs that have some behavioral changes after their diagnosis. It's the same as in people. So some dogs can become a bit more anxious or nervous or clingy. And so we do see some little changes there. So if you do see that, then that can be because of their epilepsy. It doesn't necessarily mean that they have an undiagnosed underlying disease. This next one is also true. So both cluster seizures and status are always considered something severe and need to be really well acted on. For cluster seizures, it depends a bit on what you discuss with your vet as well. We know lots of you are very well trained and know exactly what to expect. And it depends a bit on how many cluster seizures that can be when you contact your vet, but especially status epilepticus, need to seek veterinary advice immediately. Then seizure diaries are always useful, never useless. But even if everything goes well, you'd like to see that kind of logged as well, so you can look back if you do see a change and think, hey, this is a little bit different, not just the frequency, but also how the seizure looked like. Is it more or less violent, etc. So yeah, we always recommend to keep a seizure diary. Then once a dog, the last one we hear quite often, this is not true. Usually when a dog is diagnosed with epilepsy and it has multiple seizures, we put them on a drug. Yes, we barely are able to take them off. As I said, it's not common for dogs to go in remission. However, if your dog's misdiagnosed, or if an underlying cause is resolved, or it was a toxin, they don't need to be on that drug. It's not a lifelong commitment. So what is important with treatment and diagnose is that we have a thing that's called pseudo-resistant epilepsy. So we know about medication-resistant epilepsy. So when things are a bit more tricky to control. However, we see also in 1/4 of the patients that actually it's not just due to the medication. We also see that they are resistant because we're actually misdiagnosing them. So they don't have seizures, or they have a different condition, or we misclassify them, or we choose the wrong drugs, or we use the wrong dose levels. And so that's something really good to focus on. Now, with regards to what's new, 7 things that we'll discuss. One is the smartphone technology that is very recent. Oh, just admit that. That is more and more used, and we definitely promote that. Seizure detection and prediction. It's mostly clinical trials now, but we'll go over that. Then expanded pharmaceutical options, dietary optimization and microbiome modulation, neurostimulation, epilepsy surgery, and a little bit on gene silencing therapies. So the smartphone video technology is a great tool. Sometimes the description can be very accurate, however, still can look very different. So in this case, for example, an owner comes and describes that their dog had a fit or a seizure. We're very prone to call them already, to interpret a fit or a seizure with any abnormal neurological episode, and that's normal. It's something that we as humans often do. We see something, we recognize, and we interpret. So my dog just had a fit. It came on suddenly and he fell to the side. His legs were stiff and all over the place. He wouldn't respond to me calling his name, and was very distressed. It was very distressing to watch. So this is the first dog, which can be characterized by that episode. So on the side, shaking, stiff. And I think this looks quite typical as a generalized seizure. But what about this one? This dog is also falling to the side, is very stiff. But it looks slightly different. And this is where videos really come in handy, because this dog, as you can see, it's wagging the tail. It's sort of still responding, but it can't do normal movements. So the one on the left side was an epileptic seizure. So it's unresponsive. It's rhythmic jerking. So the rhythm in that video is a hallmark, but sometimes you don't get all these clues. And we can do extra investigations with brain waves where we can see abnormal brain activity. The one on the right was a movement disorder. So that's when we have this really stiffness, tremors, jerking. And when we do an EEG, so that's measuring the brain waves, that's typically normal. Now, smartphones are incredibly helpful with improving diagnostic accuracy, because sometimes we do see episodes that can look very, very similar. If it's episodic and they go down and they're stiff, it could be multiple things. We can characterize the seizure type more accurately. Sometimes seizures can look very complex, so it can be abnormal behavior rather than a motor movement, such as twitching or moving the feet. We can monitor disease progression. So sometimes we see that the seizures can look more severe or less severe, or the postictal phase looks more severe or less severe, and we can adjust our treatment plan to that. So I don't want to be the video police, and I really appreciate any videos that you're already making. You're doing an excellent job. But if we can improve it even further, that would be great. That's next level. So if you do make a video, or if you're able to make a video, what you can do is capture the start and the full duration of it if you can. Avoid it from becoming too close in the face. So see if you can get your entire pet on it. Make sure you have good lighting, and avoid excessive movement around your animal, so you don't walk through the screen too much. And also note down what the dog was doing beforehand as well. Then seizure detection and prediction. There's a few things that we have out there. So we have seizure diaries, we have wearable devices or health monitors, and we have the EEG, so measuring the brain waves. I'll just go over them. I see there are 3 little lines in the screen that I didn't see before. I'm just going to ignore them for now. So on the left side, we have, so for seizure diaries, we always strongly recommend to keep a seizure diary if your pet has epilepsy, and you can do that multiple ways. You can do the old school with Excel sheets, which is all fine, whatever works for you. However, there are more recent, kind of more advanced options out there. So we have the RVC Pet Epilepsy Tracker, which is an app that you can publicly access and download to your device. You can put your seizure medications on there. You can log your seizures. It asks you for seizure type, duration, etc. And you can even export all that information to your vet as well. So that is a handy way. Then at University of Glasgow, we use a different type of seizure log. So we ask you to upload videos. So we have all that information on your videos as well. And with that, we can better classify the episodes and we can monitor. So I'm just going to show you a little introduction on how vCreate works.
Here's how it works. You'll receive an email or text message inviting you to register for an account. Click on the link to complete the registration form, including providing consent regarding the use of your videos. It's very important to read the information carefully and only check the boxes you're happy with. Once complete, click Register and your account will be approved by the clinical team. You'll receive an email or text message once it's ready to use. You will record the videos as normal using the camera app on your mobile device. There's no need to log into vCreate at this stage. Once you've recorded your video, then log into vCreate with your account credentials and click on Upload a Clip. When logging in, you'll be able to select from a choice of languages, which translates the whole application, including messages to and from the unit. You may be asked a number of questions relating to the video. Please be as thorough as you can with your answers, as this helps the clinical team provide a more accurate and speedier diagnosis. Choose the video from your mobile device, give it a title, and click Upload to send your video to the clinical team safely and securely. Thanks for watching.
Perfect. So with this, this is software that has been used by the NHS. It has been rolled out over the entire country. We are the only veterinary service currently using this. So we're just trying to kind of go with the big guys. But so far we are very, very happy with it. And what it also allows you is that you have all your videos on your own personal account, and it's all secured. And we can feed back to you once you upload and you have any specific questions, we can answer you directly via that system. So in the future, we hope to build onto this system that you can also write your seizure logs, etc. on it. So you have one central base. So that's what we're trying to work towards. But so far, we mainly are focused on videos, but it's coming. Then we have several wearable devices, which is something that only is available in clinical trials. We've not used this in the hospital just yet. In people, there's a lot more known, and there's a lot more out there for epilepsy. You have lots of wristbands that are much more high tech than what we use in veterinary medicine. So the wearable devices, they mainly rely on biosensors. So on your heart rate, on your electrical activity of your skin or muscles, on the change in your body velocity. So all these kind of biomarkers, and we tend to use them all together to make it more reliable. So they won't replace your eyes, but they will support you, and it will allow for better seizure tracking and also less guesswork. So kind of a more peace of mind. Now, the two that we have some data for is heart rate variability. So we see that the heart rate can either go up or down right before a seizure, and also changes during a seizure. And that heart rate variability, we can measure that, we can quantify that, and we can put a threshold to that. so that it can serve as a sort of a seizure alert device as well. But this is just a pilot study, so it's not out there yet. And the second one, there's a few studies out there, so that's becoming more and more promising, is a accelerometry, which is a device that measures acceleration of the body, and with that can sense a seizure from happening. So we have it now on the chest. Ideally, you'd like to have it on the paw because there's much more movement. So there's definitely some room to improve. However, you can imagine that that's not very practical to have your dog kind of this wristband on permanently. So that is the main concern in dogs and cats, is just the practicality of it. Then there's loads of commercial available wearable technology out there as well, as you know, and I think most of you will have some kind of health tracker. They are great, and they can definitely give some clues, but unfortunately they do tend to lack real-time data. So there's a delay in when you get the data through. They're not always that accurate. They don't have continuous data recording, meaning that, for example, you have 2 or 5 minute cycles, and you can imagine that if you have a seizure that lasts for 30 seconds, you easily miss that. And it's also not validated for seizure detection at the moment. So anything that's out there, I would say be very careful, because it's not super reliable just yet. Then in regards to diagnosis, what we also really like to become more and more better in, as we are in people, and we're starting to use this more and more, is scalp electroencephalography, or EEG. It's not invasive. It does look a bit funny when you look at it on the picture, but what it does is that you have leads that are attached to the scalp, or the head basically, and they record brain waves. And with those brain waves, you can see what's happening in the brain right before, during, and after an episode. And it's mainly to diagnose seizures, but also to diagnose any other types of events. So for example, this dog here on the right, I know the screen is a little bit small, but this dog doesn't have the classical seizures. And when you just see these episodes, you're not quite sure what it is. However, if you put the EEG, which is these are all the little brain waves, you can see that this looks abnormal, or you can just believe it from me, but it looks more condensed, the amplitude is higher, and that is seizure activity. I'll just show it to you one more time so you can see what happens when the line goes over the dog's body, because you can see the dog's doing something weird there. Weird little episode, and that correlates with this activity, and looking at together we can say, okay, this is seizure activity. So in the EEG, we can use it for multiple reasons. We can use it to confirm if it's a seizure, such as in this case. We can locate the area of the brain where the seizure originates from, so we can target that more focally. And we can also see treatment response. So sometimes if we're not quite sure if drugs help, we can repeat the EEG and see if the brain waves look a bit better or maybe a bit worse, and that helps us determine whether we're on the right track, yes or no. Now, going to pharmaceutical options, we have the ones that we all know, phenobarbital or EpiPen, Zolifan. Then we have potassium bromide, also called Libramide or Vetbromide. We have imipituine, or Paxion is the brand name. And then we have levetiracetam, or the brand name called Keppra. Keppra is the one that we use usually as a bolus therapy, but these are kind of the ones that your vet and us from the neurology service and all neurologists are very, very well known with. Now, just for the chat box, and you can put it in whenever you something pops up, and we can go over it later. But I was just wondering whether you have tried any other anti-seizure medication than these 4 drugs, and how did you feel about it? Did you feel it helped? Did you feel it didn't help? Did you feel comfortable using it? But yeah, interesting to see if anyone uses anything else. Then just to go over a few that are a bit more upcoming, the evidence for all of the ones that I'm now going to mention are less than for the 4 that I mentioned before. So we always want to go to our conventional drugs first, but it's good for you to be aware that there are other drugs out there as well. So the first one that you may have heard of that is a bit more well known is called zonisamide. Zonisamide is a medication, is a drug that is quite similar to phenobarbital. It's from human medicine, and we've over the years have tried to use it in veterinary medicine as well, and we see good responses of 70, maybe even more % of efficacy. So quite happy with this medication. This has been used a lot in Japan and the US, and we are starting to use it more and more here as well. Unfortunately, it does have similar side effects as phenobarbital as well. Sometimes the appetite is a bit more variant, but yeah, the side effects are quite similar. And gabapentin is a drug that was mainly used for neuropathic pain, so neuropain, so back pain or nerve pain. However, we can also use it for seizures. It does have some side effects, and some dogs are a bit more sensitive than others, so it can be a little bit of sedative. And the evidence for this is not very well researched, so it's not really robustly proven. Then we have the stronger one, which is the cousin of gabapentin, that has a little bit more promising results. A same drug, as in it's been used for neuropathic pain and for seizures. And we tend to use this here as well, pregabalin. I'm sorry for my voice, Valerie. If you can't hear me well, just unmute, and I'll try to speak a bit louder. But I'll try to sip a bit of water now and again. Then the next one is called topiramate. Topiramate is a drug that is not often used. I would say it's maybe a handful of people that have used it. There's some anecdotal reports on it. There's not much evidence. I would say maybe as a more of a last resort treatment. One of the reasons is that it also has quite a bit of side effects, so it can cause some weight loss, some inaptitude, some say even some cognitive decline. So this one I would keep in the back pocket. Then another one, which may be an option, is called lacosamide. Again, there's not much evidence for it, but it's been proven to be very effective in people as an add-on treatment for drug-resistant epilepsy. And so far, we've not seen many side effects for the use in animals. So for this one, again, there's not a lot of evidence. It's not often used. However, it seems to be a bit more safer. But just to go back to remind you that we always need to go back to our conventional drugs first and exhaust them first, because we know more about them, we know more about their efficacy, and if they don't work, we can always talk about other drugs as well. Ada, did you see anything?
Yeah, I will interrupt you now before you go to the diet and the microbiome. So we have a few more a comments than the questions about various people experience with various medications. So for example, Kirsty had a very good experience with zonisamide. So her dog didn't seizure for a few months and then again started having focals. Christopher asked about if we see some behavioral changes on zonisamide, and some comments about side effect in terms of the ataxia for some dogs and just being tired. I don't know if you have any comments to that. Thank you.
Yeah, thank you. Zonisamide, yeah, there's been some reports on behavioral changes on zonisamide. Very sparse, though. I think there are 2 or 3 cases that had some abnormal behavior, I think agitation. So it's not common. Also, in kind of from experience, it's not common to see, but we see on most of our drugs, unfortunately, we see sometimes sporadic, odd behaviors. I would say for zonisamide, the most common ones that you will see would be a bit more sedation and wobbliness. Some dogs and some cats become a little bit more inappetent, but usually it's quite well tolerated. Were there any other specific questions, Ada?
No other specific question. There was one question about the V-Create, but we can sort it out later. So don't worry. Thank you.
Good. Okay. Next up would be diet optimization and microbiome modulation. Now, we talked about diet a few times before, so this is a little bit of a repeat, but it's important because it's upcoming and we are making some steps with it. the ketogenic diet, maybe not the best one to start off with, because we're lacking in that one a little bit. But the ketogenic diet, the basics is that it's a high fat, low carb, and moderate protein diet, and it's basically designed to mimic a fasting state and induce ketosis. So what it does is that offers the brain an alternative energy source, and in that way, it hopes to kind of calm the brain down and reduce excitability. Now, I put the little human in there because this will be mostly about people. So in people, one of the important things about the ketogenic diet is that it's not a first-line treatment. It's mostly reserved for ineffective or poorly tolerated when medications are ineffective or poorly tolerated, and it is under the supervision of a dietitian. We do have some conditions in people where we tend to go more for diet, where it's very effective, and we know that this is effective. So metabolic, genetic, drug-resistant, and infantile spasms. So we know the background of these type of epilepsies. Now, for dogs, we don't have this. We don't have that much information on genetic or metabolic epilepsies, unfortunately. We can test them, but we just don't find them so very often. So for now, we still kind of treat them as a one-size-fits-all. So we have one particular diet that is out there for epilepsy with omega-3, omega-6, MCT oil. So they made a kind of this ideal mix, which is very promising and is an amazing idea. However, because we just don't know that much about the background of our canine epilepsy, it doesn't seem to be as effective as in people. So there's been a few recent studies. The one on the left looked at it in combination with zonisamide, and they didn't really see a difference with either a diet or a not diet add-on to the treatment. They also commented that we might not be giving a high enough level of fat, so we don't get this ketogenic state that we see in people. So that might be one of the reasons. What we did find in a study on the right is that actually there's more to seizure frequency, as we said before. So behavioral changes can maybe improve with this diet. So they've seen that the dogs on this diet may become less anxious. Maybe less anxiety causes less triggers, causes less seizures. So it could definitely have a role in epilepsy treatment. Now, what we do see is that MCT oil seems to be a bit more promising. So there's several studies out there that show a seizure reduction on the MCT oil. So again, it's an alternative energy source for the brain. It can also increase other behaviors such as anxiety. It can improve alertness. It can improve quality of life. We also quite often give it to dogs with cognitive decline. So it can do other good things apart from reducing seizure frequency. It's not a replacement of medication, so it's an add-on. So it's a supplement. It's not a replacement of treatment. What is important for MCT oil is that you should always start with it slowly to avoid them from getting diarrhea. So if we want to have the amount of fat that we need to really get to an effective state, dogs can be quite prone to get diarrhea. So always start slowly when you start them on MCT oil, and I would also consult a vet. Then the most recent kind of development would be the microbiome. So there's been a lot of research now to the gut-brain axis, and we've seen that the gastrointestinal microbiota might influence neurological conditions such as epilepsy. We've seen that in people, and we also see that the gut microbiome is different from healthy dogs and from epileptic dogs, and potentially a fecal transplant can help with that. So it's quite interesting. So we think that the gut flora is different, and it may help or worsen inflammation when brain excitability. So there might be an opening there for particular diets like hyperallergenic diets, maybe probiotics, or even gut targeted therapies out there as well. So there's a research group that is working on this. Now, a question for you. how is your experience with dog diet, and have you changed your dog's diet into what, and what is your experience with it? Have you seen a change? Have you not seen a change?
We have some comments here also on the chat group about using a keto diet and then having also dogs on bromide phenobarbital and then unfortunately resulting in a pancreatitis. That's an experience from 2 people.
Yeah, that's actually a really good one to bring up, and I didn't really go into depth with it with that, but we can do that now. That's a good observation and something that we need to be cautious with. So both bromide and phenobarbital can increase your chance of developing pancreatitis. Now, the rates that we have so far in the studies are very low. However, in practice, we do see a bit more often than what we see in the studies, and especially if you add then other fatty supplements such as CBD oil and MCT oil, then that can cause a problem. So we need to be careful of that, and that's also why I do it in a consultation with your vet. So MCT oil is amazing for the pancreas if the pancreas is healthy and everyone is happy and everything is going well. The pancreas is loving MCT oil. However, if the pancreas is angry, then that can be detrimental. So we need to, exactly, you need to be careful with that. And there's always, unfortunately, a bit of a risk when we have them on all these medications. Is there anyone that has a diet that is not mentioned before, that they say, wow, this really worked for my dog?
There's one comment about the raw food diet, but unfortunately without any effect, and some people tried the NeuroCare.
Yeah. And what are the experience with NeuroCare? One comment?
I think Lindy says that she tried it, but unfortunately it didn't make a difference. Actually, the dog had more seizures.
Oh no. That's tricky. You just
No, it was the other way around. I had him on it since his
sorry.
first seizure. Just in case he didn't have epilepsy, I put him on it from the very first seizure before he was diagnosed. And then I tried to take him off it and put him onto not a cheaper diet, but a less expensive diet with MCT oil before the new MCT oil by Vet Plus came out, and his seizure frequency increased. But then I did a cost comparison between NeuroCare and the other one, the Alarite or whatever it is, and it was more expensive to buy a good diet and use the MCT oil, so I've kept him on it so far.
So you put him back on the NeuroCare at the moment?
Yeah, he's back on the NeuroCare, but now I'm kind of thinking about moving him over again. But it works out like £1.68 a day for NeuroCare, whereas if I bought a good quality diet and MCT oil, it's more expensive.
Yeah. Okay, well that's good news for the NeuroCare diet. I think if we want to do more with diets, ideally we'd have to have a good look at kind of your dog and the composition and the bloods, etc. So I definitely recommend to have a vet involved if you want to do stuff with diets. Unfortunately, as I said before, we are kind of treating them as a one size fits all with the NeuroCare diet, but hopefully in the future we'll make some advances with that as well. Then almost getting towards the end of it. So the next up is the vagal nerve stimulator. So the vagal nerve stimulator is a device that is a surgical implanted device, and it sends electrical pulses through the vagal nerve in the neck, and that helps stabilize the membranes of the cells in the brain, and in that sense reduces the seizure activity. Now, the implant itself is really small. It's smaller than a pacemaker. It's a small surgery, but it is a surgery. They need to be anesthetized for this. And it goes and it wraps around the vagal nerve. Now, what you don't see in this picture is that these dogs also have an external collar on. And that is at the moment the thing that we are trying to kind of fine tune to see if we can connect them well. But the vagal nerve stimulator has been used in people for many years, and it's been very promising and has good results. What I would say is that the vagal nerve stimulator is a long-term solution, so it's not something I would offer as a rescue option or a quick fix. So what we often see is that when we have this device implanted, that the seizure frequency might even go a little bit worse initially, and then over the course of a year or so, it goes better. What we do see very often instantly is that the quality of life of these dogs is better on the vagal nerve stimulator. So it's very promising, but there are some ifs and buts that we need to discuss before going for this type of treatment. There's a company that has just developed a new device, especially for dogs, which you can see here on the picture. We expect that this will be used more broadly throughout the UK. At the moment, there's only specific centers that can offer this. So as I said, when to consider, it would be really a long-term treatment. Then the next one has more variable results. It's also something, of course, that we take from people. So it's called repetitive transcranial magnetic stimulation. It's also a form of neurostimulation. What it does is that you have a magnetic, you give the brain magnetic impulses. The dog needs to be sedated or anesthetized. But you can see here on the picture, this dog is getting these magnetic impulses, and it helps stabilize, again, the brain and makes it less excitable. Now, the protocols are still very variable, and the responses in people, we use this quite a lot for depression. We can also use it for seizures, but the responses are, they're a little bit less effective than the VNS so far. But this is definitely also an option that we can look further into the future, and there are more and more studies coming out that show some response to this and some promising results. So why would you go for neurostimulation? What would be the advantages over the drugs that we know so much about? Well, because of the side effects. I think that's the main thing with the drugs, is the side effects. That's our main problem, and we can't do much about it apart from choosing different types of treatment options. It's adjustable and reversible, so we can stop it when we want to. We don't have to wean them off or do other things. We can use it for long-term improvements, so really look into that long-term future. It's automatic and consistent, meaning that you don't skip doses. It's always there. You don't have to think about it too much. As with regards to like pills that you have to really every day be very consistent, and it has promising results. So question for you, if this would be an option, would you consider it, or would you have some concerns about it? I'll just let you type, and then I'll go to the next thing, and we can go back to the chat box later. So the next up would be epilepsy surgery. So this is something that is definitely upcoming, and I'm pretty sure we're going to see this much more in the future. At the moment, it's only available in very specific centers, and I'm saying very because it's very limited where we do this. But this is a patient I've seen myself. So this is a little toy poodle that had cluster seizures and was diagnosed with idiopathic epilepsy, was on multiple treatments. And the surgery that was performed is called complete corpus callosotomy. Again, this is something that we've retracted from people, and in people this is very effective in certain types of epilepsy. And we've been doing this for multiple years, and we've only started with doing this in veterinary medicine over the last few years. So what is the corpus callosum? The corpus callosum is a structure in the middle of your brain that connects your left and right hemisphere, and it allows them to communicate with each other. So if you have a seizure, it usually starts in one area of your brain, either left or right, in your hemisphere. So you can see on the picture where that is located. And then it travels through the brain. And when it travels through the brain, it basically kind of involves and takes over the entire brain, and then we can see that they have these generalized tonic-clonic seizures, so these ones that they're on the side and paddling. So they start off, and maybe you can recognize this in your dog, that they maybe have some abnormal movements of the head or a bit of twitching of one side of the face. That is where it starts, and then it goes throughout the whole brain. Now, what we do with corpus callosotomy is that we disconnect the structure that allows that signal to go through the entire brain. So basically, we're stopping the seizure from becoming generalized. And how does that look like? Now, this is the brain from the side. So here you can see this structure, which is called the corpus callosum. So that is the area that you divide. So this may be a little bit more tricky to see, but these are also brains. And what we do is that we divide the corpus callosum. So that's this white structure from front to back. So we kind of walk through it, as you can see on this picture. And here you can see that here it's been divided already. Now, again, the area of the brain. So if we remove the brain and we just have the skull, this is where we would go into. This is the area. So we come from the top. And I'm just going to show you the surgery. I hope this is not distressing, but if you don't want to see it, then please feel free just to look away. So I'm just going to turn it on right now. So this is the white structure is the corpus callosum. So basically we're already inside the brain and we are really carefully dissecting that. And all the instruments are really, really tiny. And this is done with a surgical microscope. So it's very precise. And this is almost identical of how they do it in people. And that fluid there is the spinal fluid. So this is the little poodle, 5 days post-op. It's a bit wobbly, but all considering what it had to go through, it's doing really well. And then this is the little poodle, 1 month after surgery. And what we can see in these patients is that the generalized seizures are less. They may have a bit more focal seizures. So this option, obviously, with the surgery, it's a high-risk surgery. It's something that is not often done. So this is not an option that is a kind of a first-line option. This option would really be if we're getting stuck and in a very specific type of patients. So patients that are having very, very aggressive seizures and they have to come into hospital very, very often. They're not responding to any medication, etc. So it's really a selective type of patient. So when we consider this, it will have a very extensive pre-surgical evaluation to make sure that we're comfortable with doing this procedure. But as we do it more and more, I'm hoping that we can incorporate this kind of in a similar way as we do in people, and we find other ways of treating epilepsy. So a big question for you, how would you, I asked this before in a presentation, but just to see how you would feel about this procedure, how, looking at this on the pictures, etc. Is this something that you would consider? Okay, Adam, going back to you, if you want to see if there's any comments on the previous question and this question.
I think there is people were interested in the electromagnetic stimulation, and I think Kirsty asked if that she would like to try it for her dog, if that was compatible with VNS, which I think it's tricky to know until we know what is the VNS device exactly. And then
so more interest in the magnetic stimulation rather.
Exactly. Yeah. I think that the surgery, not at the moment. It looks quite invasive, so I'm not surprised. I would keep it for cases which were very refractory. So
yeah. No, I agree. Susan Ellis is making little colors on the screen. So yeah, so everything that is not so the less invasive methods people are more open for. Yeah, I can imagine that. Yeah, it might be less effective, but it's definitely something that we can look into, seeing if we can do that here as well. Any other comments, Ada? Or things?
No, there was a little bit of a discussion about still a diet, people's experience, and I think Christopher was asking about the metric trial, but I said that you mention it.
Yeah. Okay, perfect. Yeah. I think that's the last one we go to. So there it is for you. Perfect. So yeah, the metric trial is a new treatment trial for canine epilepsy, and is something that is very promising as well. And we're very excited to have it here. I'll tell you a little bit about it, but you can definitely find more information on our website. So the Glasgow University Hospital website. The metric study involves an AND134, which is an antisense oligonucleotide. It is basically it's a substance that is injected in the spinal fluid. And it silences a molecule that is associated with epilepsy, and that's how it works. It's been studied in mice before to see how safe it is, etc., if it's effective, and it's been promising. It is an experiment, so it's not a treatment option that we can offer you. It's something that we do here, which requires pre-screening, and it's based on referral, and your pet needs to be meeting specific inclusion criteria, and you can find them also on our website as well. But if you feel like your pet is eligible and you're interested, then feel free to reach out to us. So far, we have some encouraging results, and some dogs are experiencing really reduction of symptoms and have an improved quality of life. And we are working together with the human hospital with this drug, because this trial may lay the groundwork for treatment in people as well, if results continue to be positive. Ada is actually part of the team. So Ada, I don't know if you wanted to, I'm putting you a bit on the spot here, I'm sorry. I don't know if you wanted to add anything to this that I've not mentioned.
Yeah, I think we have also doggies owners. I can see Jim as well, and Jan. Hello. So they are owners of a dog who was included in the trial. So basically, I think we are still developing. We are still recruiting cases, and it's difficult to draw conclusions. But in short summary, in some dogs, it works like a magic. And we had some dogs which had really, really severe epilepsy, and then they responded very well. But for some dogs, unfortunately, it did not make a difference. And I think that depends on what you mentioned, that probably some dogs, they have different levels of that microRNA. And that would be maybe a drug for dogs with some types of the epilepsy. We classify them all as idiopathic epileptic dogs, but probably there is something more into it.
Yeah. Yeah, no, that's another aspect of the study that is really interesting, if we could get a little bit more about genetics in there as well. So this is the last slide. We're already through it. It went quickly this time. Further research topics. So I don't have any particular papers on either of these topics, but just to let you know that we are in veterinary medicine working on it and slowly making some advancements. So one of the things that we're trying to do here would be to use AI to detect epileptic seizures on video footage. This has been done in people and is working. And we're going to try to do that here as well. And then another big thing that we do in veterinary medicine is focus more on genetics. Now, genetics in epilepsy is really, really difficult. We only have two dogs or two breeds that we have a monogenic that we find a gene for epilepsy, and for all the other breeds, or most other breeds, we suspect that this might be multigenic. So that means that there's multiple genes involved, which makes it quite difficult to find that particular set of genes that is responsible. So another way to see if we can work our way around it is to go from phenotype to genotype. So basically collect loads and loads of cases, which we're trying to do at the seizure clinic, is to log all these cases and see if we can find some patterns. So certain breeds, certain seizure types, etc., and then go back from there to the genetics. So yeah, basically work the other way around comparing to people. So that's what we're also one of the big things we're trying to do with the seizure clinic. So yeah, that's a bit in a nutshell about kind of where we're at in canine epilepsy and where we're hoping to go to. I hope you don't mind that we didn't discuss a lot about kind of routine diagnosis and treatment. If you have any questions about that, of course, drop us an email. Happy to help. But I know that this audience a little bit, and I knew that you were up for a little bit more in-depth information. So yeah, thank you, and stay informed, stay empowered. And we have only one more epilepsy evening coming up. The last one will be more of a workshop. So it will be more focused on what to do in emergency epilepsy care, and it will be in the end of September. That one will be a bit more widely kind of announced, so I'll update you on that. And it will be as it will be in a workshop, it will be again in the Mary Stuart building, so on site here. So I hope to see you there as well. Just to go back to you one more time, Ada, if there's anything in the chat box that we've missed.
We have a question, the last question, I think, from Christopher, asking, how do you decide what medication to offer the patient? River was recently offered potassium bromide or zonisamide as second medication, given multiple recent seizures on phenobarbital. Some of the other drugs described also sound interesting.
Yeah, that's a good question and has quite elaborate answer. So all the drugs that we have, they all work differently, and they all have a different type of how they are metabolized. So is it by the liver? Is it the kidney? So how are your dogs or pets' liver? How are the kidneys? Does it have a sensitive tummy? How quickly do we want the drug to work? So do we want to work really, really quickly, but we're happy for it to be a little bit less powerful? Or do we want it to be more powerful and we have a bit of time so we can wait for the levels building up in the bloods? So an example for that, for example, Capra is something that is maybe not as powerful as bromide, but it works really quickly, so we can use it straight away. Then if we have liver issues, we tend to avoid things that are metabolized by the liver. As I said before, the 4 drugs that we mentioned are more conventional drugs. We know most about them, so we tend to go to them first. Maybe for your dog, for that particular type of epilepsy, one of the more unknown ones would work better. However, we always try to start safe and also with what we know and what we can expect. If that doesn't work, we can always try the other drugs, but it will always, and I explain this, it will always be a trial and error as well. So you can imagine that sometimes it's also a bit frustrating when you start a new drug. So to avoid that, we tend to go for the ones that we know usually work well. So it's very, very patient specific, and unfortunately I don't have a very kind of routine answer for you, but I hope this helps a little bit. Any other questions?
That's it, really.
Okay.
Oh, there's Lindy asking about fecal transplant. Fecal transplant is something I'm going to look into further, as PAP, Nevis, and Georgia salmonella and Yersinia. He frankly has gut bugs as we live rural. I think that would be probably, I would just answer that question, something to discuss more like with internal medicine team. I know that that's possible at Glasgow Vet School. I know that some of our colleagues which run more like a gastrointestinal clinic, they do it, but it's not very easy in terms of arranging things because you need to have like a perfect donor, other things. So that would be something more for the medicine for
Yeah.
us.
Yeah, definitely. If you suspect that there may be something pathological going on, like there's already something that shouldn't be there, even if it was a healthy dog, if you think it has increased salmonella, etc., then definitely. If we've never done it here, to be honest, we've never done a fecal transplant in epilepsy cases. I know one of my colleagues done it somewhere else, and there is unfortunately there's only one paper that shows no real difference, but it's only one dog. And I think there's so much evidence for it to maybe help. And we know this from people as well, that I think we need more information on it. So yeah, I would definitely be open to try it if anyone wants to try it, but be mindful that we don't have that much evidence. So I can't say anything about how powerful I think it will be. It's more based on theory.
And I think we have the last question is from Sue. Do you all still use warmers for your epileptic dogs?
Yeah, I don't know if that's addressed to owners or to us, but
I think to everyone.
we tend to avoid the Bravecto, Nexgard, and Simparica because there's potentially some evidence. So I usually tend to avoid these type of medications. Dewormers, I don't have a strong opinion about them. I think if you're, most of my clients, I would say, use natural products to deworm. They may be less effective, but if you're worried about adjunctive substances in it that could elicit a seizure, then you can try that. I don't know if anyone else, if the rest of the audience has their personal experience.
Mixture.
Mixture, yeah. Yeah, I think you can see this worldwide, kind of this mixture in treatments, or yeah, I think most people use natural treatments. Good. Does anyone have another question about the presentation? Then I think we'll call it a day, and thank you all for listening and for your involvement again in the discussion. I know this one was a bit short, but I would like to give you guys a break as well, because it's getting quite often every 2 months. And yeah, I hope to see you for the last one. We're also trying to get some podcasts going. So if you want to be involved, or if you have any topics you want to give us, then feel free to reach out. And yeah, thanks again for your involvement. And I wish you all a good evening. Okay. All right, I'm going to stop the presentation then. Okay, bye-bye. Good night.
Good night.
Good night. Bye-bye.